whole session is on how has the world changed with respect to COVID, and how do we gear up for a good infection control practice, management of infection control, which is a science and a business on its own in our hospitals, in the post-COVID area, and what all do we need to put in place to better ourselves, to have a very good management in place, to take care of our patients in the days and the weeks and the months to come. I'm sure this whole COVID pandemic is going to go on for another 1 year with a second wave, a third wave, and maybe a fourth wave. We really don't know because the prospect of having a vaccine seems to be still on the horizon. It may come up, but then we really don't know how effective it's going to be. Probably it's going to be something like the H1N1 vaccine, where you have a very short-lived immunity developing. And then again and again, you need to boost yourself up, depending upon how many antigenic drifts and shifts the virus is going to make. We already know that a number of mutations have taken place in the coronavirus genome. And probably what we call a vaccine today may not be very effective for tomorrow. With this brief introduction on what the whole CME program is all about, Dr. Ratnamani has effectively summarized what one could take as a message from the COVID pandemic that we've already endured to be able to do what in the future. She started off with how one needs to adapt to the pandemic, and she ended saying that we still need to learn how to adapt to the pandemic. She talked on the effects of how the pandemic has taught us to use what kind of PPE, or the effect of hand hygiene, certain lifestyle changes. Infection control was elaborated in great detail in the hospitals, in the outpatient departments, both for the clinics as well as diagnostic services, waiting areas, including radiology, nursing homes and clinics, what kind of infection control practices need to be put in, and how does one go about putting those in the post-COVID area. Rehabilitation centers and community PPEs, community infection control is something that is of paramount importance, probably, particularly with respect to public health precautions in today's world as we move forward to face the second wave of the COVID pandemic. And finally, she rounded off with a word on environmental disinfection. I think we are almost about 10 to 15 minutes behind schedule. So I'll open the floor just for one question, quick question, before we end this session. Anybody for one quick question? All right. So, yeah, I suppose you need to beat hypoglycemia also. She talked about the importance of surveillance and why we need to have surveillance. The importance of surveillance, was so well stressed on in the current perspective of the COVID pandemic. The aim of surveillance, particularly from a global perspective as well as from a regional perspective, was stressed upon. She also touched fairly in good depth on the types of surveillance, the active, the passive surveillance, community, hospital-based surveillance, sentinel surveillance, population-based surveillance, laboratory surveillance, and SARI. She also touched on surveillance and how does it impact wildlife, given the problems that emanated from China. The use of information technology in developing surveillance tools, particularly with respect to the Arogya Setu app and various other apps that have come into being in the COVID pandemic. That comes under electronic apps-based surveillance. What are the implications and what is the overall impact of surveillance in ending the pandemic? So here we are talking on antimicrobial resistance and the COVID-19. Are we really sitting on a ticking time bomb? I'm afraid I have to say yes. We are sitting on a huge ticking time bomb, and the minute it explodes, a lot of lives are going to be lost, and still worse, the morbidity of those who survive the ticking time bomb onslaught is going to be far worse than the people who depart from the earth. Why is this so? if you take a look at COVID-19 and the antimicrobial resistance, AMR, you will find that it's akin to two different pandemics. There was already a pandemic going on of AMR, and now we have another pandemic of COVID-19. If you look at the rapidity with which the two things have evolved, AMR is a slow, gradual process. It's just seeped in over the decades and the years because of our own negligence, because of our inability to curtail the overuse and the misuse of antibiotics. And probably that's what has sparked off AMR as a pandemic. It started off with small regional outbreaks, then it became epidemics in countries, then it spread to continents, and then now it's all over the world. And everyone is talking and talking and talking. Unfortunately, we all talk and talk, though, of course, a good number of countries, particularly Scandinavia and Western Europe, have really done pretty well, I must say. I dare say there are some countries, even in Western Europe, like Spain, for instance, who have not been very fortunate to have a good AMR control. But then, on the other hand, you do have a good number of Western European countries, and Scandinavia in particular, who can boast of a very good AMR. On the other hand, you do find COVID-19, which is coming like a bang. It's almost like a bang over the last 8 months. So probably we deal with two different pandemics in the world. Or is it one pandemic which is amalgamated with the other? Or will the COVID-19 affect AMR? Or will the AMR affect COVID-19? Or is it both ways? But then one bottom line is for true. The last year has changed the world. And there is no way, nobody can refute, one can refute this particular argument that the last year has seen a different and a very changed world. If you look at AMR, it's a gradual process as a pandemic which has affected multiple microorganisms. It's not just gram-positives or gram-negatives. You have even some of the non-fermenters. You have yeasts. You have fungi like Aspergillus fumigatus and azole resistance. You have viruses which have developed antiviral drug resistance. Say, for instance, H1N1 and oseltamivir, which was the last epidemic outbreak that we ever had. Infection prevention plays a very important role in controlling AMR and in establishing a good antimicrobial stewardship or an AMS program. All of us boast of good AMS programs in our own hospitals, and we say that I've got this and I've got this. But then finally, what is the bottom line? What is the overall outcome of all the wonderful AMS programs that we have is abysmal, unfortunately. But then it is abysmal, it is true. It's a bitter fact that we all have to swallow. If you test, it really tests a healthcare system. An antimicrobial stewardship program effectiveness tests your healthcare system. There are social inequalities which are amplified precisely because some of the rich demand very high on-end antibiotics, and therefore that sparks of resistance on one hand. On the other hand, you have the very, very poor in government general hospitals who also suffer from the same multi-drug resistant infections because they have acquired it in the community. You do have MDROs in the community. It's not a coveted property of public or private health hospitals. And therefore, social inequalities are brought out because of AMR. Infections because of MDR organisms are mitigated by antimicrobial stewardship programs across all centers if you have been fortunate enough to establish a very good one. There is a need to develop vaccines, drugs, and rapid tests, and also think what is the long-term effect on mortality because you have overused and abused antibiotics. Now, this is how the AMR functions as a pandemic. On the other hand, if you take the same things onto the COVID-19 pandemic, you will find a lot of similarities with very, very few differences. The first difference is AMR was a gradual pandemic that evolved over a decade, whereas COVID-19 has been a swift process. It's just wiped out so many lives. It's created havoc across continents, but you can also swiftly control it. If you are very sure about your infection control processes, you can control COVID-19 much better as compared to an antimicrobial resistance. Because there is a wrong notion that you use a whole lot of antibiotics like azithromycin, hydroxychloroquine, tetracycline and doxycycline, you use quinolones, you use ceftriaxone and cefotaxime. All of that is just dumped onto a patient the minute you admit them with a possible COVID or a confirmed COVID, as the case may be. And then this obviously just increases the chances of mortality because of the adverse effect of the antibiotics that you give patients, as well as it sparks off antimicrobial resistance. There are new treatments, vaccines, and international collaboration which is called for, but then how much of all those new treatments, new vaccines, and international collaboration that's going to happen without a war breaking out amongst continents is something that we need to see in the future. So it's very important that rapid response to appropriate measures may be palpable, but we need to make it happen. So there are a lot of similarities, but there are a few differences between the two pandemics, probably that are happening in parallel. There is an interaction between the two emergent pandemics that has happened. So that leads us to think that the two emergencies are probably intertwined. Ill patients are at an increased risk of secondary bacterial or fungal infections. We have seen a lot of our COVID-19 patients not die of a COVID coagulopathy. They develop secondary bacterial pneumonias, Acinetobacter baumannii calcoaceticus pneumonias. They die of Klebsiella pneumonias. They die of bloodstream infections secondary to monoclonal antibody, tocilizumab, being given, like Hiton to these patients. And the next thing you know that, lo and behold, you get bloodstream infections due to carbapenem-resistant Klebsiella pneumoniae. You have all kinds of funny things happening. So what is predisposing to the other? Nobody really knows. You try hitting on one thing, another thing comes and hits you. Symptoms of COVID-19 most of the times can be associated with overuse of antibiotics. You can have an incessant cough, a fever, but you can also have a drug-induced fever. You can have an antibiotic-associated fever, but you can have a fever because of COVID. So it's a whole lot of things which are intertwined. There is a rapid interplay between COVID-19 and AMR. So the same attempts that you make to manage the spread of COVID-19 may also help to bring down the adversity of AMR. It means very strict hand washing, you use a face mask, social distancing, keep a lot of space between two patients. This is something which we've been talking about, but never did anything about it. That's because nobody bothered. Whereas now when there is a pandemic, then we say, yes, I must cover my mouth, I must cover my nose, my face should not be seen, my hands must always be washed. I sit over here and keep using sanitizers. Catch me doing that 6 months ago. Never did I ever use sanitizers. I used to hate the spelling of sanitizers, but then today I love it. That's because I don't want to suffer from COVID-19 if I can help it. So there is a lot of intertwining between the two pandemics. There has been a general failure of AMR control, if you see the right side of it, and all those things are multiple factors that have come across, that have come to fail MDR prevention and control. To add some insult to injury, or it's like pouring ghee into the fire, you have the AMR casualty in COVID-19 on the left side. Clinical service protocols have been disrupted because of rapid changes. There has been a disruption in global antibiotic supply chains. There is a tendency to overtreat hospitalized COVID-19 infections. That patient doesn't improve, so you dump something. Again, he doesn't improve, so you give an antibiotic, a higher one, meropenem. And then he still doesn't improve, so you give an antifungal, then you give an antiviral. Anyway, remdesivir goes on. So there is a lost, the focus on AMS programs has been lost over the last 6 to 8 months. There is a tendency to use certain antibiotics along with antiviral agents. A classic example being azithromycin, maybe an antiparasitic like hydroxychloroquine. A double crisis, particularly in lower and middle income countries, I'll just come to that, with a very high risk of environmental transmission. So what is the impact of COVID-19 on the AMR scenario? There are some actions which have already been implemented on the left-hand side. Those are listed with respect to AMR. They came up in 2014, largely because of the efforts of the WHO and the UN, with clinical and microbiology surveillance, promoting rational and controlled use of antibiotics. Somewhere down in 2011 or 2012, WHO considered AMR as a medical emergency. All right? So with that, all these things came up, that you must have very good antimicrobial stewardship program, you must develop tools for rapid diagnosis of ID, and so on. But then what have the demands of the COVID-19 pandemic been on these developed tools for AMR surveillance and control? Unexpectedly, you started using antibiotics, and that too in huge excesses, like azithromycin and hydroxychloroquine. On the other hand, because of limited supply chains, you have had a problem in giving antiretrovirals in a proper supply of anti-tuberculous drugs. There has been limited access for patients to go and pick up something from somewhere because there is no transport. And a village is something like, say maybe 100 kilometers or 200 kilometers from the nearest public health center. And they do not have timely access to drugs. So therefore, you've had antiretroviral resistance. You've also had tuberculosis resistance, MDR-TB. There is a stop on research and development because all funds and resources have been diverted to COVID-19 research. There is a risk to vaccination efforts. I'm sorry for the S missing over there. It's risk to vaccination efforts. There is a disrupted agricultural industry. That's because you don't know how much crops will come up. There has been a shortage of manpower and labor tending to fields, tending to animal husbandry. So when there is a problem over there, what do? You tend to use antibiotics to get a better produce. Fatten up your pigs, fatten up your cattle, fatten up your goats and sheep so that you get better mutton, better chicken, and so on in a short period of time. It has not happened in a timely manner. That's the whole problem. These are the stewardship challenges in lower and middle income countries, taking India as an example. What are the diagnostic challenges? Do you have good primary care laboratories with diagnostic facilities? I'm afraid we do not. Many infections are underdiagnosed and treated empirically. Yes. Clinical microbiology facilities, even within hospitals, is limited. That is why we have very few of our testing centers, even for COVID-19. There is a lack of essential information for clinical decisions, and the policy making is a huge challenge because 50% of our problems still remain unclear with antimicrobial stewardship. On the other hand, you look at knowledge and awareness, even worse. Optimal antibiotic use awareness among physicians still remains low. Catch the GP, refraining from using antibiotics. They would love to use antibiotics to increase their practice. AMR is not considered a significant problem in practice, even with some of our well-touted physicians, though everyone talks about it. That's why I said right at the beginning, everyone talks about AMR and a beautiful AMS and all that, but hardly anyone practices it the way it ought to be practiced. Prescriptions are freely available. You even get antibiotics freely. You can go purchase meropenem. You have the money, go purchase meropenem and inject yourself. Nobody's going to bother. None of this is audited. No pharmacy audits exist at all. There is a lack of local high-level evidence, and experience impedes guidance writing. There is a lack of comprehensive understanding of available guidance. You take guidance from Western countries, but then how do you apply it to the Indian scenario? There is really no awareness of that. There is an economic and social implications of COVID-19 on AMR. This has had an impact on national economies with widespread unemployment. Personal savings have been largely depleted with economic downturns. That has also affected production of antimicrobials with huge losses. That's because everybody has gone on sick leave, people have taken COVID leave, there is a long recovery time. If you develop COVID, anywhere between 2 to 3 weeks is lost in you staying away. And then people who are next to you, close contacts also go into quarantine. So if they are also working in similar industries, even they take leave. And there is a large neglect on this. There are some ethical issues as well. If you look on the left-hand side, you will find these are the issues with hospitalization. Longer hospitalization times, too many investigations. Never have I seen so much of prescriptive evidence for IL-6, TNF-alpha, procalcitonin. Hundreds and thousands of tests being done across the country per day. And over-enthusiastic antibiotic therapy. There is an increased risk with common surgical procedures, even an appendicectomy or even a simple tonsillectomy does need a COVID test. All this, with the increased amount of antibiotics being given to patients, has increased colonization with MDR bacteria. That has led to hospital-wide outbreaks with limited bed space. So does this open up an ethical issue? Not everybody gets a bed. There was a time in Hyderabad where people used to fight to get a bed in some hospital, right? And there was a mixture of COVID-19 infected patients and non-COVID-19 infected patients, and any of these people could have a medical, surgical, an obstetric, or a pediatric emergency. But then still, the problem existed about getting COVID beds and non-COVID beds, both. So is there an inherent risk? Did we put ourselves in the medical community to a risk of caring more for some patients while ignoring others who actually may have needed more and desperately urgent attention? Yes, probably we all have been guilty of doing something like this. So our lives and is healthcare being sacrificed on the altar of caring for COVID-19 patients? That probably has led to some amount of increase in mortality, morbidity of patients, and an increase in the AMR. Do we have co-infections, and how has it affected AMR in the COVID-19? There are some mechanisms of superinfections. If you hospitalize a patient, put patients in the ICU on the ventilator, many of them are critically ill and are at an increased risk of co-infections. This is one mechanism. You could also have an immune dysregulation with fungal and bacterial proliferation with elaboration of cytokines, and there is an immune-mediated lung damage which predisposes to superinfections. But then there is a general paucity of data because of all these reasons. That's because either your laboratory is too overworked with COVID-19 that nobody really has the time. The general thing is, I'm busy with COVID-19. You talk to anybody these days, no, I'm very busy with COVID-19. I don't have time for the other work, which we are actually supposed to do. Generate data, look at data, analyze data, do good infection control practices. Yeah, but I'm doing all of that, but then for COVID-19. So what about the rest of the work? Just too bad. It's gone out of the window. Now, this is just to give you an overview as to how co-infection gives rise to various kinds of exuberant inflammatory responses and to explain the pathogenesis of how co-infections give you a lot of secondary bacterial fungal infections and therefore contribute to AMR. This is the potential impact of COVID-19 on MDROs. Say, for instance, if you have infection control practices and PPE use, you could have a shortage of PPE with increased admissions in COVID-19, and that can favor an MDRO transmission. You can have an overcrowding of hospitals. It increases the need for more beds, so you try to put beds together, and that is one of the reasons why MDRO organisms can transfer from one person to another. You can have a shortage of nursing staff. You've had perennial shortages of nursing staff even before. Now it's been even further aggravated because of the COVID-19 pandemic. That increases the chances for nosocomial infections and antimicrobial resistant infections. And finally, the elderly, the immunocompromised, prolonged hospitalization, mechanical ventilation support, all of this has taken its toll on increasing the chances for antimicrobial resistance. This brings us to the concept of One Health view of COVID-19 for AMR. It's a sustained public health emergency, whether we like it or not. There is an overuse and a misuse of antibiotics during the COVID-19 pandemic, which could trigger AMR. The agents for COVID-19, you could use multiple antibiotics and say, this is working, azithromycin is working, doxycycline is working, everything is working today. But what about treating brucellosis 10 years down the line? You could have drug resistance. What about treating rickettsiosis 10 years down the line? We still see a lot of scrub typhus. We see a lot of epidemic typhus in India. And how are we going to treat those if you keep using doxycycline and azithromycin to treat COVID-19 without any evidence to do so? MDR infectious organisms decrease the survival from serious infections, neonatal infections, and hospital infections. So it has increased the mortality. Similarly, the worst thing that's happened is you don't have enough chicken, you don't have enough livestock to fall back on for food. So how do you fatten up? How do you get more poultry? How do you get more meat? By using antibiotics to feed up to fatten up chicken. So therefore, it's believed that you can get better chicken, more flesh. but then you're using more antibiotics in animal husbandry, and that can increase the amount of antibiotic resistance in human beings. How has the healthcare system adapted on AMR, adapted in COVID-19, and how does it affect AMR? There is an increased focus on hand hygiene in hospitals, which is very good. There is a social distancing both in hospitals and in community, though it is not very prevalent everywhere, but still, to some extent, it does help. There is an opportunity for isolating patients who are either colonized or infected, so therefore it works beautifully. You preemptively discharge patients and cancelling surgical procedures, that is wonderful. Diverting PPE from COVID-19 patients, but then that's not very good because it spreads MDROs. There is an increased rate of telemedicine, which can have both a positive and a negative effect, because when you see somebody online, you're not examining a patient. You say, ha, theek hai, you take all this. So you write one big list of medicines and give it to them on the WhatsApp. And that WhatsApp is gone and shown to the pharmacy, and that pharmacy fellow adds one or two things more. Ha, iske liye ye bhi de do. So it is like 6 becomes 8 and 8 becomes 10 by the time that man lands up with a nice big set of pills in his hands. There is a redeployment of AMS teams, whichever nurses you employed yesterday to look after antimicrobial stewardship as a team nurse is going to be taken out from there and say, no, I mean, we need people to work on the COVID ward. So put that nurse over here. So what happens to your AMS program? It goes for a 6. So that's what happens because of rapid reorganizing of teams and recruiting more people with no training, no time spent on them. And of course, there is an overcrowding and overloading of the healthcare systems. The whole scenario on AMS is actually unclear. There was a study in Pittsburgh which demonstrated that there has been a reduced monthly antibiotic DOT. DOT is days of therapy, and the bed days of care between March and June 2020. But if you look at the bed days of care and to take the days of therapy through June, that was increased as compared to previous years. They found a significant increase in anti-pseudomonal penicillins and macrolide agents, which are actually the first-line agents for the treatment of community-acquired pneumonia, or CAP. Prescription patterns have also been very, very different. That's because a physician may not really be able to make out whether this is COVID-19 associated LRTI or whether it is a community-acquired pneumonia, non-COVID-19, and that problem still persists. You go, do a test, it's negative. You do a second test after 3 to 4 days, it's negative. By the time you go on dosing the patient with antibiotics, increasing the chances of colonization with MDR organisms. So this group has come up with something like, divide all your patients into 4 groups. Those where there is no evidence of a secondary or a co-infection, you don't give any antimicrobial therapy. The second group is those who present with a possible co-infection, probably you could give empiric agents, but then you must rapidly de-escalate. Those who present with a co-infection, which is about 19%, agents directed narrowly against known or most likely pathogens in the lower respiratory tract, Streptococcus pneumoniae, Haemophilus influenzae, meningococcus. These are the ones which you must target. Those which develop a secondary bacterial infection or a fungal infection while admitted to the hospital, there you could probably use your broad-spectrum antibiotics and antifungal agents. These are the lessons that we have learned from COVID-19 and how do we translate it to AMR control. We must prepare to face the healthcare burden of AMR by doing all of this probably. The most important being hand washing, increasing the bed strength capacity of hospitals, laboratory detection of AMR programs, invest in very good community services like water, sanitation, and hygiene, and develop systems to prevent resistant infections. These are some of the recommendations probably which could tackle AMR in COVID-19. Don't give antimicrobial prophylaxis for mild to moderate COVID-19 disease when there is no clinical features of bacterial infection. Consider your host factors and epidemiology. If there is a moderate COVID-19 disease with pneumonia, or if it's an elderly patient or an immunocompromised, give antibiotics. But then recommendations are enhance your key competencies to detect, identify a secondary bacterial or a fungal infection rather than at random giving antibiotics to people. Focus on strict infection control measures. maintain a regular quality supply chain of assured antibiotics, ATT, and vaccines, reduce the turnaround time for COVID-19 so that you can decide whether it's a CAP or whether it's a COVID-19 pneumonia. Exercise great caution while using biocides for environmental and personal disinfection. And of course, fill up your gaps in AMS research so that it becomes an integral part of addressing the COVID-19 pandemic. Probably that will go a long way in also addressing an AMR pandemic.